Hi friends, in today's podcast from CSI West Bengal branch, I am Dr. Hazra here with my friend Shilanjan. Welcome Shilanjan.
Thank you.
Dr. Shilanjan Roy, can you tell me about yourself?
Yes, I am.
Currently what you are doing?
Firstly, welcome to all the viewers who are watching this podcast today. And thank you, Dr. Hazra, for inviting me to this podcast.
It's a new initiative from CSI West Bengal branch.
It's a very welcome initiative for general awareness regarding heart diseases and various risk factors for heart diseases. I am Dr. Shilanjan Roy. Presently, I am working as an assistant professor of cardiology in KPC Medical College in Kolkata. Also attached as an consultant interventional cardiologist in Charnock Hospital, Kolkata.
Great. So today's talk will be on lipids, cholesterol, dyslipidemia. You know, dyslipidemia can kill people, and if it starts very early in their life, like familial hypercholesterolemia, it can affect any age groups, any ethnicity, any race, any religion, any sex at any point of time. So what is dyslipidemia or high cholesterol for common people, Dr. Shilanjan?
Yes. The medical term dyslipidemia that we use, commonly we can tell in a colloquial term that altered blood lipid parameters, or there are different lipid fractions in the blood. Alteration of these lipid fractions as a whole, as an umbrella term, we use this term dyslipidemia. There can be many patterns of dyslipidemia. Different fractions can be higher in different diseases, but commonly the strongest risk factor or the fraction of the lipids that is most attributable to development of heart disease or directly linked with the development of atherosclerotic heart diseases or cardiovascular disease as a whole is the LDL fraction that has got the most widely studied and most wide data that possibly
so that is bad
the
cholesterol.
Bad cholesterol. Yes,
so
absolutely.
Is there any good cholesterol?
Yes, the HDL fraction, which usually acts as one of the carriers of cholesterol that reduces the cholesterol content from the atherosclerotic plaque. This is usually termed as the good cholesterol, and usually a higher level of this HDL cholesterol protects us from development of
But there is no
atherosclerotic
good therapy.
diseases.
There is no good therapy for good cholesterol.
Yes, till now, many therapies has been tried, particularly focusing on increasing the HDL levels because it has seen that higher HDL protects from heart diseases, heart attacks. But unfortunately, all of the therapies that has been tried nearly for last 3-4 decades, various classes of medicines has been tried. They have shown a good result in increasing the numerical values of HDL, but unfortunately that numerical increase in the HDL levels has not translated
You can forget about HDL cholesterol.
Yes.
You should focus on bad cholesterol.
Yes.
So there are bad cholesterol in our human body like LDL cholesterol, small dense LDL particles, lipoprotein,
remnant cholesterol, LPA.
LPA. So there are therapies for all these things.
Yes.
Now, you know that this cholesterol very early in their life, placental life, newborn, they have cholesterol, small numbers, but with increasing age, progressing age, bad lifestyle, smoking, etc., your level goes up.
Absolutely.
And how it affects the survival or the living, or how it gets deposited? Can you highlight this part of our knowledge that how it progresses, how it affects our cardiovascular system?
Yes. So the study of cholesterol or the evolution of the cholesterol in the human being and all the mammals has been a wide topic of research. It has been seen that from the birth itself, we have got a level of LDL cholesterol or the bad cholesterol in our body, though it's at a low level of maybe 30-40. As with our increasing age at the adolescent, in the early puberty, the level increases. With bad lifestyle, all this constellation of other risk factors like smoking, hypertension, obesity that you have already told, improper dietary habits, LDL cholesterol rises. And possibly this is the main culprit fraction of the cholesterol that leads to deposition of the atherosclerotic plaques or lipid plaques within the vascular tree. Not only in the arteries of the heart or coronary arteries, but also anywhere in the body. It can be in the brain, it can be in the kidneys, peripheral arteries. These LDL culminates into high LDL levels, develops, it's a main propagating factor for the development of this atherosclerotic plaque that leads to the blockages of the vessels that can lead to reduction in the blood supply to that particular organ. When it is in the heart, it can lead to ischemic heart disease. When this plaque ruptures, can develop into acute coronary syndrome or MI, myocardial infarction. So with increasing level of LDL cholesterol, it has been seen that it is one of the principal drivers or principal risk factors for the accelerated progression of these atherosclerotic vascular diseases.
So in essence, you are saying the same good arteries which can prolong our life makes our life, makes you to survive by transporting blood, oxygen, nutrients to the heart, to the brain, to the legs, to the kidneys, to the organs, gets narrowed with time because these LDL cholesterol or other forms of cholesterol, with time they get deposited. And the same process is accelerated by smoking, lack of exercise, etc.
Diabetes.
So what is the most important organ in human body where this cholesterol plays a pivotal role in causing deaths and mortality and morbidity? What is the most important organ?
Possibly the most important will be the heart, wherein the coronary arteries, it produces atherosclerotic plaque, the deposition of the lipids, and these inflammatory processes accelerates, high LDL level accelerates the atherosclerotic process, the plaque builds up. At times, this may rupture, can develop into acute myocardial infarction, acute coronary syndromes, which can be instantly fatal. Even in the younger ages,
So that means you are saying all this can progress with time. Is there any method of reversal, like the plaques or the blocks or the passage narrowing, which has developed over time because of unfortunate habits of smoking or diabetes or genetic reason? So is there any method of reducing the progression, the speed of progression or regressions of your atherosclerosis blockage?
Yes, definitely, because these atherosclerotic process, as we have seen, apart from certain genetic disorders that we already mentioned briefly, that in these cases, it's very difficult to prevent the atherosclerotic process. Some people have got genetic lipoprotein defects where there are very high LDL cholesterol from the birth itself that leads to accelerated atherosclerotic process. They can get heart diseases even in their teens. But in normal individuals, the process of atherosclerosis start at the age of usually 18 to 20, as has been confirmed by autopsy studies. But interestingly, we know that some people develop heart diseases, some people they do not develop heart diseases. And possibly the difference lies in the presence of risk factors. Some genetic factors which are non-modifiable, that is not in our hands. Some are highly modifiable factors like smoking habits, like diabetes,
so these are the
obesity, triggering
factors,
hypertension that we have already discussed, that leads to eventually endothelial dysfunction, vascular stiffness, this deposition of lipids. So if we can aggressively modify all these risk factors, majority of them being the lifestyle, risk factors, if we can modify, properly control the hypertension, control diabetes, control this dyslipidemia with medications, maintain a good body weight, proper stress-free lifestyle, we can definitely retard the development of atherosclerosis or atherosclerotic plaques.
So there are situations where people wonder, why did I get heart attack? My LDL cholesterol is normal. So there are people who has got very minimal risk factors, get maximum life-threatening event like sudden cardiac death, multiple blockages in the coronary arteries. The simple LDL cholesterol normal doesn't mean that he is protected. There are, on the other side, many people have many risk factors, but they live, they smoke. But that's not a guarantee or an example.
Absolutely. These are exceptions.
These are exceptions.
These are exceptions.
So what is the level of LDL cholesterol at which the human beings are protected from recurrent heart attack, first stroke, first leg problem, kidney problem? So what do you think the ideal LDL level in the human being should be to prevent even the first heart attack?
That is a very, wide topic of discussion, because our understanding of these levels of LDL, the cutoffs of LDL, how low LDL is best for human body, is still evolving. The concept is growing day by day, the scientific understanding is growing. But as far as present understanding and the present guideline directives are there, some late international guidelines that it states that to some extent the LDL level we target, or the LDL which is best for a particular individual, depends not only on a particular value of LDL, it depends upon multiple factors like the age of the person, whether the person had any previous history of atherosclerotic vascular disease or not, naturally a previous heart attack or previous stroke or previous peripheral arterial disease, any blockage in the body that has been previously led to any vascular events, automatically places that person at a very high risk of subsequent events. So these patients are very high risk. They need aggressive lowering of the LDL cholesterol, possibly to a level below numerical value of less than 30, which our present understanding, scientific understanding goes. Patient who is diabetic for a particular duration, long duration diabetic patient, diabetes with other diabetes related complications like CKD, proteinuria, these are all, additional risk factors that poses a higher threat for development of future events. Presence of strong family history. Patient may be asymptomatic, but some imaging proven presence of pre-existing atherosclerotic plaque, though it may be silent in any part of the human body. These are the high risk factors, and in this patient, possibly targeting an LDL below 50 and in some high risk cases below 30 may be beneficial to prevent a future development of another event.
Right. So we need medicines, we need lifestyle modification, exercise, etc. And there are newer medicines like cholesterol vaccines, twice in a year, inclisiran, evolocumab, gene editing, all these are available. But again, these therapies are very costly. Common man cannot afford it.
Availability is restricted.
Is definitely a problem. All people cannot afford it. Only few people can afford it. But it has got its own place. The best medicine is a statin, we call it statin. And how do you convince a person, those who are having a cardiac kind of no cardiac illness or asymptomatic, cardiac health checkup been done, and they're perfectly fine. Still, they need some medication to lower the level of LDL cholesterol. So how you convince your patients about lowering the LDL, the benefits of lower the better or the lowest is the best of LDL. Even then, some people may listen to your advice, may not listen to your advice.
Absolutely.
But at least our duty to tell the patient that what type of patients population they should take cholesterol or statin therapy, even if they are not suffering from established heart disease, stroke or peripheral vascular disease.
Yes, it's a very pertinent question, sir. And the first thing is that I want to emphasize is that education is possibly the cornerstone in maintaining a high level of adherence to statin therapy or any cholesterol lowering therapy. In each clinical visit, we have to emphasize, reiterate, and explain the importance of adhering to a lipid lowering therapy. And primarily, statin is the first line agent or the cornerstone of dyslipidemia management in the entire world. Particularly patients who are diabetic, having atherosclerotic, risk factors for the development of heart disease like smokers, hypertensive patients, or multiple these risk factors. These patients has to be explained that they are candidates for statin not only for the lipid lowering or achieving a certain target, but also this is a medicine that will prevent them from heart attacks and stroke. And this is actually a medicine for their overall cardiovascular health. So it is not about a particular level of LDL. Definitely we have
and this should continue like that.
And this medicine has to be continued. Once they have been diagnosed with diabetes after a particular age, irrespective of their, in majority of the patients as far our present guidelines and understanding goes, irrespective of their LDL, majority of the patients, diabetic patients will be requiring, along with their glucose lowering medicines, a statin therapy. So that in every visit we have to, educate the patient, explain the patient about the importance of this particular class of molecule, also making them aware about their particular LDL targets, about the risk factor in the risk category in which they are falling, and to explain them that this is your baseline LDL target. For you to be, to be achieving a lower risk of development of cardiovascular disease, your target should be this, and for this we require this you to be to continue this molecule. Probably you will need it to continue lifelong, and depending on your response, we have to modulate or adjust the dose of the medicine. And secondly, one thing I want to tell that.
So how high dose? Like there are two statins, like atorvastatin and rosuvastatin. So people have an apprehension of 80, 40, 20, 10. 10 is the best or most frequently prescribed statin dose. Do you think that there is a need for high dose of statin to prevent a further event in human beings, or 10 milligrams good enough? So high dose statin, what is high for you, or it's high for common people or to the patient?
I think that the high dose statin or low dose statin, the high intensity, moderate intensity statin, it is entirely, it should be tailor made and patient centric. There is no hard and fast rule that that particular dose of statin or that particular dose will suit all. It should be tailor-made depending on the patient's
So one size
clinical
does not fit all.
Absolutely. One dose or one size does not fit all. We may have to add on non-statin agents also. If a patient requires that his LDL is not coming down even with a higher dose
side
of
effects,
statin or side effects, patient is, we are restricted to use a higher dose of statin because of intolerable side effects of that particular class. We may have to consider or resort to some other class of agents. But so it's not about a particular dose of statin, but it is about particular targets that this patient requires to, need to achieve for that particular patient, keeping in mind the multiple risk factors of that patient.
Friends,
There
I
are
think,
concept of primary prevention, secondary
so almost
prevention.
we're coming to the end of our podcast conversation, a beautiful conversation, a sweet conversation, a futuristic conversation, a progressive and protective conversation to stay healthy and young, to prolong life, friends. Now, the last leg of our discussion, side effects. Side effects prohibits or prevents us from prescribing good medicines for good cause. So what are the important side effects of taking statin? And there is a myth that once you start taking, you have to take it lifelong. They stop, they check every 6 months, 1 year. There's no point checking your sugar like LDL cholesterol every month. So what are the major side effects which prohibits somebody taking statin for lifelong, and how do you tackle those things? That will be a last question in our podcast.
So in statin, majorly statins that we prescribe, majority of the patients in Indian context, we have seen that they tolerate statin pretty well. In some patients, there are issues with some muscle symptoms. That is a very common, probably the commonest side effect of statin. Patient might develop some muscle pain, discomfort in their muscles, some muscle enzymes may rise. These are indications that this particular statin might require dose reduction, or we might have to consider giving another group of statin. If the patient at all cannot tolerate statin at any dose, patient developing unpleasant muscle side effects or some serious side effects we can see as clinicians, then we have to choose some non-statin lipid-lowering agents in place of statin. But by and large, it is very well tolerated agent. Some molecules have shown slightly increased risk of diabetes maybe in certain individuals. So patients who are pre-diabetic and we are giving this or starting this particular class of statin, we might have to be additionally conscious whether the patient is developing, having new onset diabetes. But usually aggressive lifestyle modification, body weight reduction, if all these things go hand in hand with proper monitoring, we can circumvent this side effect to a large extent. And otherwise, these are some technical issues that we have to monitor: the liver enzymes, the kidney function when we are using statin, high dose statin particularly. That depends upon that particular patient's clinical status. But by and large, statins are very well tolerated. And if at all patient develops simple muscle symptoms with some dose modification, some
vitamin D,
etc., some muscle vitamins that can solve the problem to a large extent.
Right, friends. Today's CSI West Bengal podcast has highlighted the importance of taking care of your health, especially your cholesterol, the health of LDL cholesterol, the level of LDL cholesterol definitely is very important to live longer. And it does cause heart attack, strokes, a leg problem, kidney problem, etc. And knowing the medicines very well, the side effects of the medicine is definitely the issue. Cost is an issue, but these are much more affordable and economic brands.
The benefit,
far higher than the cost and the side effects. And these are two forms like atorvastatin, rosuvastatin, mainly pimpoitic acid, and azithromycin is also available in combinations. So statin is important, and statin can prevent heart attack. Cholesterol lowering can prevent stroke. There is no doubt. So please subscribe to our channel and wait for the next podcast series. That's all from today from CSI West Bengal branch. Thank you,
Thank you,
Dr. Shilanjan.